Hello, and welcome to this activity, Pembrolizumab, Nivolumab, and PD-L1 markers. This is a follow-up conversation to what we recorded in June on the then emergent PD-1 inhibitors, Nivolumab and Pembrolizumab. I'm Jared Weiss, Vice President of Cancer Grace and a head and neck medical oncologist. And it's a great privilege to introduce my colleague, one of the smartest oncologists I know and an all-around nice guy, Dr. Josh Bauml from the University of Pennsylvania.
Thank you very much.
So when we last spoke in June, we were looking at trial data and anxiously awaiting approvals for multiple PD-1 agents. Maybe we should start by just reviewing the key results and where we were at then.
Yeah, absolutely. So what we saw in those two trials in Keynote 12 and Keynote 55, which were two studies evaluating pembrolizumab in recurrent or metastatic head and neck cancer, we saw that pembrolizumab had significant activity well beyond what we would expect of a historical control in recurrent metastatic head and neck cancer, the majority of which was refractory to platinum, and in Keynote 55, refractory to both platinum and cetuximab. In Checkmate 141, this was a randomized study that evaluated nivolumab as compared to the investigator's choice of single-agent cetuximab, methotrexate, or docetaxel for platinum-refractory head and neck cancer. And in this study, an overall survival benefit was seen with nivolumab superior to the investigator's choice. At this point, both pembrolizumab and nivolumab are FDA approved for platinum refractory head and neck cancer that is recurrent and metastatic. And one of the major questions that I get as from community oncologists is, how do we choose between these two agents?
Well, I guess it's my turn to chime in. I see these agents as rather similar to each other. And the real answer to the question is with essentially no passion, I choose between them. I have two drivers, though, that lead me in my practice to use almost exclusively pembrolizumab. The more important of these two drivers, and the one that should matter to the world, is the dosing schedule. In my practice, and I'm guessing in yours as well, some patients travel from a great distance, and some of these are poorer patients with limited means, and nivolumab is an every 2-week drug, whereas pembrolizumab is every 3 weeks. The other big driver that wouldn't be a driver at all if I had any reason to believe that one drug was safer than the other or one drug was more efficacious than the other, is that I have a lot more experience with pembrolizumab, having treated a lot of patients on Keynote 12A and B and 55 on it, and of course doctors are creatures of comfort in the absence of a reason to do otherwise. Is your practice at all different from that?
No, my practice is identical to that, and some of the pushback which I've heard has been that, you know, with nivolumab we have randomized data showing an overall survival benefit, but I think the key thing when you look at overall survival benefit is, what are you comparing it to? So in the Checkmate study, 52 of the 121 patients who were randomized to investigator's choice received methotrexate. Now, this is not a drug I ever use in the treatment of metastatic head and neck cancer. While it is a historical comparator, it's simply not an agent that I use, and I don't have a great deal of confidence in its efficacy. So while they did see an overall survival benefit, really what that overall survival benefit was compared to was not meaningful enough to me to exclusively use nivolumab. And like you're saying, I really feel that these have similar effectiveness. And if we look at the response rates, of course cross-trial comparisons are fraught with bias. We look at the response rates, it's pretty similar. The toxicity is pretty similar. And I feel more comfortable, as you're saying, with using pembrolizumab in this space.
So one of the questions I get the most from both patients and some of the community doctors that I collaborate with is when to use these agents off-label, when to consider them in the absence of platinum refractoriness. And so I'll ask you, are you considering these at all for patients for anything outside of the pure label?
Most of the time I am following the label because the platinum refractory nature is something that's mostly surmountable if we have a patient who has metastatic disease and they've not received platinum ever before. Giving them something like carboplatin paclitaxel is generally pretty well tolerated. And if I don't think that they can tolerate carboplatin and paclitaxel, I usually take a step back and see whether I should be treating them at all with systemic therapy. But the one place where I am pushing the envelope a little bit is on Keynote 55. They had to be 6 months to the day. They had to progress before that. And if someone was 5 months, I might hedge a little bit on that point because clearly, 7 months, I might hedge a little bit and say, this wasn't an effective drug for this patient.
Yeah, I agree. I might push it a little bit further. I've had patients, where they appear cured at their primary site, the local regional site at the primary, and the neck is clear, and they have the tiny lung nodules that you're following, and maybe biopsy proven to make this a little cleaner, although to be honest, not always. And the growth rate is starting to bother me to make me think I need to do something, but I've been tempted when I'm not as scared of the cancer to bring IO in a little bit earlier for its better toxicity profile. And some patients who push for it where it doesn't seem frankly wrong, I'll admit I've used it some off-label.
And I think that that's a great point because given the lack of impressive efficacy for recurrent metastatic head and neck cancer, I think my tendency when I have these tiny nodules that are too small to biopsy has historically been to just watch them a little bit more than I would watch, let's say, metastatic lung cancer, which tends to grow more rapidly because there are a group of patients with metastatic head and neck cancer who just have these little nodules and they sort of putter along for a little bit. And I think that in this situation, using immunotherapy has a lot of benefits. It's well tolerated. They can maintain their quality of life. I think it's a great idea.
Yeah, the other place I've used it some, and I'm not sure that what I'm doing is right, is in that patient that I'm really on the fence about whether I would, in a pre-immuno era, whether I'd give them a chemo or not, where the kind of case that one of us might run by each other, is this someone who's more likely to benefit or to be harmed? And I'm hemming and I'm hawing to say, that balance is a little different with the PD-1s. And I have a few times in such a patient given them Pembrolizumab and hope for the best. Of course, I reserve the right to be wrong. I don't know this is the right thing to do.
But I think that brings up a really important point with these agents because we still really do not have a good predictive biomarker to determine who would benefit from these agents. In CheckMate, patients were more likely to benefit. Their overall survival benefit was only seen in PD-L1 positive cases as in HPV positive cases. But the label is agnostic of PD-L1 status. And in the Pembrolizumab studies, as you know, the incremental benefit was not seen for PD-L1 positivity. So there was greater benefit than historical control seen for both PD-L1 positive and PD-L1 negative tumors. And indeed, the only impact of PD-L1 positivity on responses at all happened when we included the immune microenvironment, which is not the standard of care usage of the DACO assay. So I think that it is really important to advance the science and figure out how we can predict this, because the patient who you're describing, if we had a theoretical biomarker X that said, look, this person is 80% likely to respond to this drug, yeah, I might do it off-label in that situation. And that sort of science is really essential to move us forward.
Yeah, it sure sounds like it would be nice. So just to summarize, am I hearing you right that you're not using PD-L1, HPV, or any other biomarker to select patients right now?
That's exactly right. I do not use PD-L1 to choose who will receive the agent because benefit was seen with and without PD-L1 positivity. And HPV similarly, we saw benefits in HPV positive and HPV negative cases. At this point, the other biomarkers are not clinically available. They're really in the research realm. But I'm hopeful that in the future they'll move to the clinical arena.
Yeah, I couldn't agree more strongly. So just continuing the theme of who to treat, one common question that comes up in clinical practice is the patient that has some pre-existing autoimmune disease. These are not uncommon, and I feel like maybe it's just the random luck, but I feel like lately I've been addressing this question a lot. Had a patient with rheumatoid arthritis for whom this otherwise would have been right, patient with psoriasis for whom this otherwise would have been right, and one with a kidney transplant, which I think has an easy answer. Have you confronted this a lot in your practice with in the trials we all had very clean populations of people with none of this. In the real world, of course, we're sometimes between a rock and a hard place. The rock being we don't want to hurt people. That's not what we're there for as doctors. On the other hand, when people are running low on other options and the cancer is really hurting them, we have a strong drive to try to do something about that.
Yeah, I've definitely encountered this, and it's a big problem. As you mentioned with the transplant, that one's an easy one, because, or a relatively easy one, because what we're seeing more and more is that when we give these agents to patients with solid organ transplants, it seems that their organs fail. And that's a big deal. Now, in some situations, that is, an acceptable compromise. A person's going to die of their cancer if they don't receive the agent. And in the case of a kidney transplant, especially if it's going out anyway, they may be more amenable to that approach. But in the case of a patient with a heart transplant, that's a very different circumstance. In contrast, I've spoken with my colleagues in melanoma where there's much more data about the use of these agents because they've been using immunotherapy for longer than we have. And generally the attitude is a discussion with the patient, a discussion with the physician, talking to other providers. I have a patient who I just recently started on immunotherapy who has vasculitis and rheumatoid arthritis, but for various reasons, we know this patient has a high likelihood of responding to immunotherapy. I had a frank discussion with her, and I said, listen, yes, you're at an increased risk for side effects, but if we don't treat this, we know what's going to happen. So I think as long as we're having engaged communication, we'll be able to move forward. And I think that probably the toxicities associated with some autoimmune conditions is likely overblown in much the same way that all the trials exclude patients with hepatitis C and HIV. And I think that the emerging animal data is saying that these populations may be safe to receive these drugs.
Yeah, I strongly agree. In the case of the transplant patient, of course, I didn't do it. But if you look at the melanoma literature, they claim and granted, head and neck may not be the same as melanoma. They claim they get away with it 60% of the time. And recognizing that some of the time when you don't, quote, get away with it, you can still rescue with steroids if you're monitoring really, really carefully. And in my practice, I would say that's the more important thing. You brought up the point of a frank conversation with the patient, which is probably the most important point. I would add as a second most important point that if you do it, it should be monitored really carefully. Whatever you're afraid of, look for frequently so that you don't risk keep going if there's a problem.
Yeah, so what I've done in the past is usually I give these drugs and I'll give it to them and come back in 3 weeks with your dose. But what I've done is I'll say, okay, I'm going to have you come back next week just to see how you're doing and do that for the first couple of cycles and see how we're doing from there. And then if they tolerate it, then I'll space it out back to normal.
Yeah, this is exactly what I'm doing. And I have gotten away with it a few times where patients have benefited and not had exacerbations of their underlying condition. I'm sure if I keep doing it, I'm going to see some bad complications. But I guess the question is in the balance whether it's worth it, whether we're helping more people than we're hurting.
The other interesting thing which I recently saw is I was giving this to a patient, giving immunotherapy to a patient who had another malignancy, in this case a hematologic, a myelofibrosis sort of picture. And we're going to have to see what happens, but it looks like its platelet count is coming up. So we're learning more and more about drugs and how these interact with people. So
well, that one sounds worth writing up. That's an interesting.
We're working on it. The patient needs a bone marrow biopsy to see if we're really seeing reversal. But it's exciting. With these drugs, we're only just starting to learn the impact of them, but we're also starting to learn their limitations and when we should best use them.
So Josh, you've seen a lot of patients on PD-1 therapy between the trials and now standard of care use. What toxicities have you seen in your practice? And I ask for this audience in part because the toxicity tables that we show aren't always quite what we see in the real world.
Yeah, I think that's true. I think that the big things that we see frequently, I see fatigue, but the fatigue is nothing like what patients who are on chemotherapy receive. So, you look at the toxicity table, you'll see fatigue, but fatigue is on every toxicity table for a cancer clinical trial.
I agree. It seems exaggerated. What I'm hearing from patients is not as bad as what our toxicity tables seem to imply.
The thyroid dysfunction is real. It's something that we watch quite closely, and that can also impact the fatigue. So if someone starts developing hypothyroidism, treating that aggressively. Similarly, I'm very concerned about pneumonitis because pneumonitis can occur. It is quite dangerous when it does occur, but in distinction from other forms of pneumonitis from cancer-related therapies, there are two good things about the pneumonitis related to PD-1 inhibitors. First of all, it's highly responsive to steroids, and second of all, the majority of people who are able to be tapered off of their steroids can be re-exposed to PD-1 blockade without recurrence of their pneumonitis. There was just a series published in JCO in lung cancer showing that 75% of patients were able to be re-exposed to PD-1 blockade without recurrence. So this is really critical in terms of the management, understanding how to use these drugs. And then the other thing is that if you have a patient who's still quite fatigued or having issues with their blood pressure, I think it's really important to think about their adrenal axis as well, because I have seen that as a problem.
These are things that would be tested with laboratory tests in a tired patient. So in our last recording, we talked some about this phenomenon of pseudo-progression. And just to remind the audience, pseudo-progression is a phenomenon that was seen a lot in melanoma where it looked like the cancer was growing, and then it ended up not being the case. And we talked about this last time as being a less common phenomenon by a fair amount in head and neck cancer. So just as a follow-up to the real-world experience, have you seen any of this since we spoke in June?
I've seen one case. And I've given a lot of PD-1 blockade in that time.
Yeah, so that speaks to me pretty strongly if you saw only one. What I've seen a lot of is that like a week or two out of the Pembro, people having what looks like an inflammatory response in disease in their neck, or the primary when it's visible, almost looking infected, like a little red, a little angry, but not frank pseudo-progression where, where prior to immuno you would have called this progression. And they seem to calm down by the second treatment cycle.
Yeah. I think if by the first scan they're showing evidence of progression, I'm pretty convinced that that's true progression. And I think it's also important to remember that the definition of pseudo-progression requires that they're asymptomatic. These are not tumors generally, especially patients with local recurrences who can have progression of their disease without symptoms. So as much as I love to wear my optimistic oncologist hat, I think it's important
I thought it was the only hat we all owned.
Well, I have two hats. Just for when it's cold outside, I need to have another hat.
That's what happens when you live up north.
Yeah, up north it gets cold. We just were snowing. So, I think that while I want to hope for that, I think we need to be realistic about the fact that the rate of pseudo-progression is really quite small. And there again, whether it's through a radiographic or a serologic biomarker, I think that's a clear need clinically to be able to say look, we're seeing this, and as a result of this, the likelihood of pseudo-progression is very low.
Yeah, I agree. I mean, I haven't seen it since June, other than this little inflammatory things, typically with the first cycle. And I think the key point is, there's a lot of culture around wanting to hold on to these agents because of the real hope that they offer for durable control. But the practical lesson is that if it's growing, it's probably just growing, not some funny phenomenon. So the other question that I'm getting a lot in practice and from some of community docs is when we're going to be ready to integrate these agents into cure.
That's an important question.
Right, because that's most of our patients, right? Are locally advanced patients being treated for cure. I've had patients come in specifically asking for these agents, of course, using their brand names as part of curative intent modality. I have never done this outside of a clinical trial. Have you ever tried to use these agents as, neoadjuvant, so before attempts to cure or together with radiation or anything like that outside of a trial?
I have not, and I think that it's really important that when we combine these drugs with things like radiation, it's very important that we recognize the risks that are inherent with that proposal. I think a lot of people got excited many years ago when there was this case report of a patient with melanoma, a young man, was treated with ipilimumab for melanoma, went on hospice, and got a single fraction of palliative radiation, and then went into a CR. And this led to this idea of this abscopal effect and this Radvax effect, and it gets everyone very excited that you're going to radiate things. It's going to release neoepitopes or neoantigens, so cells that make the immune system get excited, and that's going to lead to a more robust immune response. So the first thing is that, yeah, there likely are neoantigens that are released. That's probably a thing that may amplify an immune response, but that has not been proven. But I think the other side of this issue needs to be considered. The potential risk about giving these agents with radiation is that if I give someone PD-1 blockade and their tumor dutifully fills with T cells that are robust and want to kill that tumor, then I radiate their tumor. Just logically, that doesn't sound like it would be a great thing. So I think we need the trial data to show whether it's a fantastic immune boosting effect, whether it's middle ground, doesn't do either way, or whether it's potentially harmful. And really the trials are essential to answer these questions.
Fair enough. While we're talking about trials, anything you're working on you're very excited about?
Yeah, so we have a multi-institution investigator-initiated trial that is evaluating Pembrolizumab after definitive intent treatment for very high-risk patients, so patients who have very bulky lymph nodes. So this is a multi-site investigator-initiated trial that I'm running with Tanguy Seiwert at the University of Chicago, who was on the prior recording. And so this is going to be a randomized trial where patients will be randomized to Pembrolizumab for 6 months to a year after their definitive intent therapy, or either observation or placebo. That's a bit of a work in progress, but it's looking like it's going to be observation, and then seeing how they do in terms of progression-free survival. And this, I think, is a nice trial design because it's taking patients who are at that minimal residual disease state and giving them immunotherapy then, which is really the time when immunotherapy seems to be most effective in other formats, for instance, in stem cell transplant for leukemia. So I'm excited about that trial to proceed. How about you?
Like
Do you have
trial.
Down in North Carolina?
Yeah, we have a few things that I'm excited about. For this call, one thing I might mention might be we have a trial combining Pembrolizumab and radiation. It's for patients for whom the standard of care for cure would be the combination of cisplatin and radiation, but who aren't eligible to get cisplatin, perhaps because of something like pre-existing hearing loss or mild kidney impairment. And then the other way we're trying to integrate these agents into cure is as neoadjuvant or induction therapy prior to surgery. So we have a study making its way through what will probably be a long regulatory path with carboplatin, nab-paclitaxel, and durvalumab prior to curative intent surgery. That's making its long, winding way through. And what I like about that one is that we'll have paired tissue before and after treatment to be able to compare and see what changed, and we'll be getting some blood along the way as well, so that when it works, we might maybe understand in who it's going to work the best, and when it doesn't work, maybe be able to explain why so that we can better design future trials.
I think those are both great trials, and it'll help answer the question, with radiation and PD-1 blockade, as I was saying before. And this sort of induction approach has really been helpful in other tumors where we've been able to better understand who's likely to respond to chemotherapy and why, and similarly for immunotherapy. So I think those are going to be great trials to advance the science.
So it's been a wonderful discussion. Anything else that you wanted to talk about?
No, I think this has been great. Thanks so much for inviting me to come back and talk about this.
Yeah, it's really exciting that at intervals this short, that there's legitimate advances going on and movement in the field, and so many trials. We've discussed some of our own, but there are plenty of other exciting trials going on. We'll soon have completion of multiple phase 3 trials addressing the role of immunotherapy as the first treatment for incurable patients, and a lot of other cool concepts making their way either through trials or through their regulatory process at a pace that I'm not sure has ever happened in head and neck oncology ever before.
Yeah, it's an exciting time to be an oncologist, certainly in head and neck. It makes me want to put back on my optimistic oncologist hat.
It's a great hat, and that might be a good note to end on.